Welcome to Health or Consequences, the podcast by Commonwealth Magazine. I'm John McDonough from the Harvard Chan School of Public Health, and my co-host is Paul Hattis from the Tufts University School of Medicine. Welcome to everybody. Today we are absolutely delighted to welcome Dr. Monica Bharel, who is the Commissioner of Public Health for the Commonwealth of Massachusetts and has more issues on her plate today and just about every day than anyone could imagine. We are delighted to have you. Welcome, Commissioner. And let me just start by asking you, before the Department of Public Health, you were the Medical Director of Boston Healthcare for the Homeless. Can you tell us a little bit more about your background and how your work with Healthcare for the Homeless informs your role at the Department of Public Health today?
Sure. Thank you, John and Paul. It's just wonderful to be here with you today and talk a little bit about all the great work that's happening at the Department of Public Health. I am trained as a general internist. I did my training at Boston University and what at the time was Boston City Hospital, and have been practicing general internal medicine and primary care for over 20 years and feel really fortunate to have worked in many different environments, including at city hospitals, community health centers, VAs, and as you mentioned, 12 years at Boston Healthcare for the Homeless program. And I feel truly honored to have worked with my patients, from whom I learned so much about what it means to try and access care when you're sick and to try and find opportunities to be healthy. And what really is most important to me that I learned from my patients is that all of us want to be healthy and find opportunities to be healthy. And when my patients needed treatment for things like their diabetes or their congestive heart failure, I was able to tell them how much insulin to take or get them an appointment for the cardiologist they needed to see. But I had less answers for some of the things that they were really struggling with, like where to store their insulin when they were sleeping under a bridge, or how to get access to low-salt diets when they were sleeping in their shelter, or how to remain safe at night. And for me, these experiences and being able to see these tremendous spirits, work so hard to take care of their health, it really made me think at the individual patient level, there's things that we can do to help them treat their disease. But there's so much more that needs to be done at the systematic level to make healthy opportunities more attainable for all of us.
Okay, great. Let me turn it over to Paul Hattis. Paul?
Welcome, Commissioner Bharel. You know, we're sitting here on Halloween Day, a little bit over a month since you, Governor Baker, with the support of the Public Health Council, took the important step, some would say, of banning the sale of all vaping products, given some of the public health concerns that have emerged. Since that time, a number of different events, and courts did get involved when some challenged the ability to issue that ban, and we stand here today where the ban is in effect. For the cannabis portion, it goes forward, but on the nicotine side, you're now involved in a little bit of a regulatory hearing and comment process tied to that. We've also had the second death, sadly, of someone with a vaping history, I think, of just nicotine in our state. Tell us, a lot's been going on, your thoughts about everything that's emerged to date, if you would.
Yeah, thanks, Paul. It's a really important issue for us to be talking about right now. So, if you think about e-cigarette and vaping use, this really came to our attention in public health a couple of years ago when we started seeing these alarming numbers of youth and young people beginning to use these devices. They're relatively new in terms of being around. They've only been around since about 2007. And we started seeing in Massachusetts many more youth and young people using them. So if you look at 2017 data, you'll see that high schoolers, over 40% say that they've tried it.
Tremendous proportion.
Really unbelievable. And here in Massachusetts, over 20% of high schoolers are using them regularly. So we began working over the last year to address this youth and young people, a real epidemic of e-cigarette and vaping use. And we know that nicotine is addictive, and nicotine is so dangerous to the brain, the developing brains of youth and young people. So we began a campaign to make sure that the e-cigarette and vaping use did not lead to another generation of individuals addicted to nicotine. And as part of that, we did a lot of education with young people, educating each others about, there's this myth that a lot of young people believe that e-cigarettes are quote unquote the safe cigarette, and we really needed to have them be educated and understand. And parents and teachers said we didn't know, that these devices look like slick little USBs and are being brought into classrooms. How do we catch up and make sure that we're protecting our youth? So in that context, where we've been doing a lot of work with communities around e-cigarette and vaping in young people, we began, unfortunately, in August of this year to hear about this alarming new pulmonary disease associated with e-cigarettes and vaping in all age groups. So the CDC started reporting on that in a dozen or so states. And here in Massachusetts, we said we need to understand how is this disease impacting us in Massachusetts. So on September 11th, through our authority at the Department of Public Health, we mandated reporting of any pulmonary disease related to vaping to the Department of Public Health. And, before we mandated that, we were hearing about a couple of potential cases here or there. But unfortunately, after we mandated it, the numbers just started to come in. And every day we started to hear about multiple cases. And now we're up to over 200 cases have been reported to us at the department to investigate. When the ban was put in place by the governor on September 24th, it came in the context of saying we don't know what this disease is caused by. We don't know whether it's the device, whether it's one of the products. And in order to be able to keep individuals safe in Massachusetts, we'll ban temporarily all of these. It pauses it. It gives us a pause so that we can better investigate these cases.
Let the science move forward.
Understand the science and work with our federal colleagues. And just to give you the numbers, we so far are up to reporting 20 confirmed cases to the CDC and 41 probable cases, and our investigation is ongoing.
Okay. Now, you mentioned the broader concern, public health concern about vaping, and so part of the policy discussion in our states also included what should we do about things like flavored vaping products? Mm-hmm. And should we add taxes to vaping products because they don't currently have the kind of taxes that we, let's say, place on regular cigarettes? Any thoughts about those subject areas?
Yeah, as we think about what should be the regulatory framework within which these exist, I first want to say that, all of us are looking to the solution to tobacco and cigarette smoking. Tobaccos and cigarettes are deadly, and we want to have a solution. I'm just not sure that e-cigarettes and vaping, which are currently not regulated, available in multiple flavors, and the long-term benefits are just not known of them. So in that context, what we see as attractive to youth, which I mentioned to you we're very concerned about, is easy access, cheap pricing, and multiple flavors. So sometimes children are picking up these flavors that are available in bubblegum and mango and fruit medley and not even realizing what they're using. And we know that when flavors are limited, children are less likely to use them. So that's going to be a really important part as we move forward as a state to think about how do we get these devices and these flavors out of their access to youth and young people so that we have less people starting to use them.
Okay. Let me turn the subject a little bit to something that also makes the paper, especially in the summertime, which is equine encephalitis or West Nile virus that can result in humans from mosquito bites. Now, we know that DPH follows those diseases when they occur. But when it comes to trying to mitigate or reduce the risk, even though you're at the state level, there's workings with local government on issues like spraying. Tell us a little bit how you, working with local government, try to balance interests there, especially with people wanting to be outdoor in the summertime doing activities versus the risk of a bite.
So, you're right. This has been, unfortunately, a very active year for eastern equine encephalitis. And when we think about triple E, as it's called, triple E is rare, but unfortunately, it's one of those diseases that's carried by mosquitoes. You get it from a mosquito bite. It's rare, but if you do get it, it's very serious and unfortunately can be deadly. Mm-hmm. We've had a very active year for triple E this year in Massachusetts. We've had 12 cases, and very sadly, 3 deaths related to that. So our job is to make sure that individuals understand what the risks are of triple E. Because it's an active year, we worked very closely with our unbelievable partners in local health and individuals across communities to make sure that folks understand the most important thing about triple E, which is personal protection. So making sure, the hard things like changing our behavior. So wearing mosquito spray, wearing long sleeves, staying inside. And what we try to do at the state level and in collaboration with our local partners is make sure that we put out all the information and people then can make informed decisions about balancing their risk and understanding what their health outcomes are.
And the spraying issue at a municipal level?
So we work very closely with our colleagues across state government and with our mosquito control programs to understand where spraying needs to happen. We did a tremendous amount of aerial spraying this year as well as local spraying, and that really is a piece that adds to the personal protection piece and the behavioral piece together to make sure that we help people protect themselves as best they can.
Okay. So, Commissioner, you've been in your job now since 2015, and I think for most of your tenure, the major issue that the public has been concerned about is opioid addiction, opioid abuse. Can you tell us where the Commonwealth is at right now and how we stand in relation to the rest of the country in terms of addressing and dealing with and trying to reduce the problem?
Absolutely, John. So when the governor came into office in 2015, he appropriately named addressing the opioid epidemic as his number one health priority. And at the Department of Public Health, we have been working tirelessly since 2015 to move forward the governor's action plan on how to address the opioid epidemic. And there's a couple of things I want to say about it. When you look at the current opioid epidemic, it takes the lives of about 2,000 individuals in Massachusetts. So let's pause for that for a second. That's 2,000 preventable deaths here in Massachusetts. So we have been laser focused on working with our communities to decrease the number of deaths and the risk for individuals. One of the most important things for us related to addressing the opioid epidemic has been to address it through a public health lens. So that means looking at prevention as a core. So for individuals who have not been exposed to opiates, making sure that the risks are understood, making sure that young people understand what the risks are, people understand that fentanyl is now present and deadly and a part of this opioid epidemic, and then making sure individuals who are using have access to the life-saving treatments and things like Narcan to reverse an overdose, have access to treatment, and really importantly, have access to a stable recovery. Part of what we've seen is that because of this multi-pronged community-based approach that we have, is that Massachusetts was one of the first states to see a decrease in the number of opioid deaths. So just to give you a flavor of that, if you look from 2013 to 2014, we were seeing about a 40% increase in the number of deaths, right? So almost doubling. And in the last couple of years, we've seen about a 4% decline. So what that shows us is that we're seeing a steadying of these deaths and are starting to see a decline. So the interventions that we've put in place are beginning to work. But it also tells us there's much more to do. We have to keep at it and continue to increase access for individuals most at risk in order to stem the tide of these deaths. I must say that decrease is happening in the face of rising numbers of fentanyl use. So unfortunately, when people die, 92% of them, 92% of the times when we look at autopsies, fentanyl was present. So fentanyl continues to be a problem, but we're really seeing unbelievable responses at the community level where communities are coming together and saying, in our community, how do we educate, how do we prevent disease, and then how do we make sure people have access to treatment? I will say that one of the things that we continue to work on is the issue of stigma. There's lots of opinions people have about opiate use and about it being a personal choice or about a decision that someone's making. And we've worked really hard to help individuals understand that opioid use disorder is a medical disease that deserves to be prevented and treated just like any other medical disease. And we're seeing it change. We're seeing that stigma being lifted. And I'm really hopeful that we'll continue to see a decline in the number of deaths, which really is devastating of course, to the family, but to all of our communities when you lose a loved one.
Is there anything that needs to be added to your arsenal of approaches and tools to try to address it, or do you think you have what you need right now?
What we're doing right now is what's most important right now in our response to the opioid epidemic is to continue to move forward on this path of preventing disease, so preventing individuals who don't have it, and then increasing access to the life-saving mechanisms of things like Narcan, treatment, and recovery. So it's about continuing the current work, but I will say that we are really focused on making sure that individuals who are at highest risk have the capacity to access this, and we're making the services as accessible as possible. So there are certain communities that we have found are unfortunately at increased risk for overdoses and death, and we're really focused on making sure our services are getting to those. So those include individuals with a history of co-occurring mental health issues and addiction. It includes communities of color. It includes pregnant and postpartum women. It includes individuals with a history of incarceration and those with housing instability. So we're making sure that our services are really accessible to everybody.
Thank you. Paul?
Commissioner Bharel, I'm going to shift the focus a little bit away from some of the traditional areas like nicotine, opiates, and mosquito-borne illnesses to an area that our podcast listeners might not always be aware of, that your department has responsibilities on sort of the healthcare system side. In particular, you oversee a determination of need, some states call it a certificate of need, set of law and regulations when a major hospital capital project or a hospital merger is planned by one of our healthcare organizations. In reviewing the history of those projects, it didn't come to either John or my attention that the Public Health Council, which is involved in that review, has actually ever stopped any of those from going forward. Does that sound right to you? And if so, your thoughts about that?
You know, I don't recall one of the projects ever being denied. However, what I do want to focus on is what we're doing now to increase accountability in our determination of need program. In 2017, we did a major overhaul of the Determination of Need program, which really hadn't had an overhaul like that since the 1970s. And think about how much healthcare has changed.
You wrote the whole regulations.
Since the 1970s.
Yes.
And so there's some really important aspects of the Determination of Need now that I believe make it stronger and make it more appropriately focused on public health value. So, for example, in the past, an individual hospital or facility would talk about the improvement that they were making and how they believed it would improve their patients' care. When they presented that to the Public Health Council, it was kind of a snapshot in time, and then they moved on with their project. What we put in place in 2017 is a reform that really, instead of looking at the individual facility, looked at the entire healthcare system. Many facilities are now part of a healthcare system, and looked across that healthcare system about how all individuals in that system would have improved care. The other thing we put in place is an annual reporting process so that each year the healthcare system would now comes back to us and really reports back on how the project is going, which adds accountability. And then we also have the capacity, if needed, to connect that to future DONs if they're not able to improve the public health value as they said they would. So I believe these improvements are really going to help us, one, modernize the DON to be appropriate for the healthcare system we're in now, and also to be able to help us improve the way we deliver care in Massachusetts.
In the last couple of years, with some sensitivity, I think, both to access and cost a little bit, the Public Health Council has added conditions to some of the projects. Children's Hospital's building a major building. B.I. Leahy is now merging. How do you feel about that process to date and some of those transactions and the review and the conditions that were added, especially in the cost realm potential worry, I should say?
Yeah, so the way that we now have some standard conditions that we put in place with all determination of need projects, and it really helps us to be able to set a baseline of what the expectations are of our colleagues in the healthcare system, and it includes some really critical pieces like language access, participation in mass health, as well as the annual reports I mentioned, and it also allows us to standardize the way that community health funds go out to the community. So it's a really important part. And, we've been nationally, people have been interested in how we've thought about our community health investments. And for the first time in Massachusetts, we've set state public health priorities that we ask all healthcare systems to actively engage their communities in and have those communities be active participants to be able to move upstream from what I spoke about earlier, focusing on the disease, to thinking about how we live in a healthy way in our communities. So those 4 areas include some of the things actually we've been talking about: prevention of chronic disease, addiction treatment, mental health and wellness, and housing and homeless instability. And a community can decide to pick something else, but many communities have picked projects in those areas. And it's about thinking about, we want to be able to provide disease care in our healthcare systems. It's so important. And in Massachusetts, access to care is something that we've worked on for a long time, and it's really critical when someone's sick. However, we also know in Massachusetts and across the United States, still, our zip code is far more important than our genetic code in terms of how healthy we are. And what we're trying to do with these changes is shift our thinking of health to be in the community and make real commitments to communities being healthy so that all of us, regardless of our background, our income, have opportunities for health here in Massachusetts.
Okay. I'd like to shift to a topic that's very hot right now in the legislature, which is the issues of vaccines and preventing childhood illnesses. There are 2 bills in the legislature right now. One would just eliminate the religious exemption that allows people not to have their children vaccinated. That's been done in a number of other states. Another bill would give the Department of Public Health much more broad regulatory authority over reporting and other issues relating to vaccines. This is a big issue all over the country. How big a deal is this in Massachusetts? Can you contextualize? Do we have a problem with vaccination? And where does Massachusetts stand, do you think, as you think about what approach you want to take with these bills?
So first, John, I appreciate that opening to be able to remind all of our listeners that one of the biggest advances in public health and health ever has been vaccination. So I urge everybody to be up to date on their vaccinations. It's flu season. Get your flu shots. This preventive piece is one of the most important things you can do for your health. When we look in Massachusetts at vaccinations, I'm really proud of the work that we've all done here together. School-age children going into school here in Massachusetts have very high levels of vaccinations for things like measles and mumps, above 95%. So I'm really proud of our collaborative work across Massachusetts. Of course, there's more work to be done, but I think we're on the right track here, and it's really important for those of us in health and public health to continue to make sure that the facts and the important benefits of vaccine are shared broadly.
Okay. So final question, and this is a broader question. As Massachusetts Commissioner of Public Health, you are the leading voice on public health and the health of Massachusetts public. You also get to participate in national organizations where you actually have a national voice through things like the Association of State Health Commissioners and so forth. This morning I saw on the news an alarming increase in obesity among young adults, children between ages 2 and 17. And if we look across the spectrum of the health indicators in the United States, we have 3 years of declining life expectancy. We have exploding obesity. We have an epidemic of gun violence. We have the worst rate of any country in any developed country on maternal mortality, on infant mortality. As you look at the big picture, is public health failing America, or is America failing public health? Why are we so unable to make the advances that we see among every other advanced industrialized nation? What's gone wrong?
Well, John, I'm a realistic optimist. So my take on what we're doing here in public health, it's really based on thinking about the people who are doing the public health work and the health work across Massachusetts and across the country. If you talk to the individuals who are doing the day-to-day work to keep us all healthy, these are tremendously talented, well-informed, hardworking individuals who are doing a lot to prevent disease. And when things are prevented, we don't always hear about it. So there actually is a ton of really important good public health working here and across the country. That said, it is true that in the United States, we have a problem in the way we think about health. We are, of course, the country that spends the most on healthcare and has some of the worst quality outcomes when it comes to healthcare. And to me, this comes back to thinking about how we look at health versus disease. And, in Massachusetts, we've made it a baseline that we are going to give individuals access to health care. We still need to do that at the national level. Access to healthcare is really critical, and you can't treat disease without it. But again, thinking more broadly about health, there's a way that we need to think about our resources, our existing resources, and shift and align them to think about how people live healthily in their community. To give you an example, at the Department of Public Health, since 2015, we've been working on a public health data warehouse. And as part of that, we're taking information from across different state agencies and looking at them and linking them at an individual level for the first time in Massachusetts. And that is allowing us to really, truly understand, with, by the way, data that we already have, how do individuals access services across Massachusetts? We've used it a lot to address the opioid epidemic. How do we think about someone's mental health issues, addiction issues, health issues, how they're living in their community, what things they're exposed to, and help individuals make more informed decisions. So we're turning data into information and putting it out to our community partners so that they can then use that data to use their existing resources to actually improve health for individuals. So, and I think it's a model that's working, and there's a lot of opportunity for us to improve health that way.
But would you agree or disagree that the United States is failing on public health?
I think that in general, in those of us working in public health are making improvements every day that really makes all of us safer and healthier. In Massachusetts, we pride ourselves in being a leader in public health. We're one of the healthiest states in the country, and that's based on, again, access to really good, high-quality health care and also a laser focus on smart health policy, and all of us as a community in Massachusetts saying we demand health for ourselves and our loved ones and working towards that together.
I did a little analysis for Commonwealth Magazine last spring where I compared Massachusetts versus other leading nations in terms of the basic health stats like life expectancy, infant mortality. We are mediocre to poor compared to all of these other nations. So we look good in comparison among the 50 states, and we actually look pretty mediocre to poor when we look at ourselves versus other nations.
And I think what that raises is that there's always work to do. And there are, when you think about a place that's as healthy as Massachusetts, there are individuals within our communities, many of the patients I care very deeply about, who don't have access to those opportunities. So our job is to make sure that we improve access to those and work towards health equity for all of us.
Okay.
Commissioner
Bharel, thank you.
Lots going on. Thank you so much for coming today.
Thanks for having me.
Pleasure to have you. Thank you. So, Paul, as we've started to do, where after our guest leaves, we talk about them behind their back. One of the things that strikes me is we covered so many bases in such a short amount of time with Commissioner Bharel. And I'm also just so aware that for every issue we talked about, I can think of 10 issues that I wish we had time to talk about because the plate at the Department of Public Health is just so full of so many compelling and important issues to the Massachusetts public. Just something that strikes me whenever we get into the public health space. What do you think?
Well, John, I agree. And even for the issues we talked about, sometimes there's aspects of that the commissioner can't get into. So, for example, one that interests me in the vaping space and why they find themselves, in a court process is this whole issue of even when you think you have a public health emergency, it doesn't give you an automatic right to ignore traditional comment and rulemaking, which is part of an administrative process in issuing a regulation. And so now they're in court, and actually after having been in court, reissuing a regulation and going through that process when they didn't the first time around. And I think for a lot of us, there's sensitivity when we look to Washington, amongst other places, and see that the rule of law isn't always respected. So that's one thing that she couldn't talk about that I thought about. The other that she could have talked about but didn't was when she went through the DON areas, and talked importantly, about some of the access issues around some of the public health investments that accompany, some of the transactions. She didn't talk about, even though DPH as DON has some responsibilities here, some of the cost growth implications of whether it's building a large building and adding new beds or mergers. And even though, they are tiptoeing into that space, I think there's a lot of us who worry about the cost growth of those projects, hoping that DPH, its staff, and the Public Health Council can more assertively enter that space in some of the conditions that they write. And she sort of decided not to talk about that aspect at all. So how about you? What's
very interesting? Just one more thing, and then we'll close off with just, I guess it's a little bit of a rant, not at the commissioner. I've watched all four, I think it's been four, of the Democratic presidential debates, and noticed that for the first half hour to 45 minutes, every single time they argue about Medicare for all, which I think is an important and compelling conversation to have. And it just drives me crazy, though, that we spend so much time on that, and in not one of these debates have we heard a word about declining life expectancy in the United States, exploding rates of obesity and overweight among adults and children, the shameful rates of infant mortality and maternal mortality in the United States, and on and on. And I wonder why it is that people just don't pay attention to this stuff. And it's one of the frustrations we all share in the sphere of public health. But it just strikes me particularly with all of the incredibly important issues that we were able to discuss in this brief interview with Commissioner Bharel. But anyway, so that's my rant of the month. And thank you, Paul, as always, for being my generous and vivacious co-host. And we will be back again next month with another Health or Consequences. Thank you all.